Well, welcome everyone. This is the third official discussion of the creation of the Massachusetts Health System Benchmark. And just to remind everyone that this critical issue really undermines and really is the key core of what we're all about here in the state. And so this is a very important hearings, and I'm so pleased to welcome as Chair Benson and Chair Friedman from the House and the Senate, just to remind everyone what we're all about. The state, in passing the Section 224 in 2012, put in this idea that healthcare spending throughout the state should not grow by more than the growth in the state income, and what was critical about that decision was really two things. One, it recognized the need for growth, but it recognized that we have to have the capacity to pay for that growth. The second thing that it recognized and separates Massachusetts from most other parts of the country is that the state, the legislature, and the governor recognized that we were talking about total health care spending. We were not just talking about the Medicaid budget or about what private insurance, that ultimately we have a health care system which is very much interrelated, and one needs, from a state perspective, to look at total spending. And in creating Section 223, it created two separate organizations which work very closely together: CHIA, the Center for Health Information and Analysis, and the Health Policy Commission. And the governor was nice enough to appoint me as the chair and to be part of this process. So what we're all about today is to get a sense from the major participants, players in the system, about their views about this benchmark. And so that's, and to do that, at some point, I'm going to ask the executive director of the Health Policy Commission to give us a background. But before I go any further, I just want to turn to the chair, if there's anything you'd like to say to get us going.
Sure, thank you. Thank you, Dr. Altman, and members of the Commission for inviting us to come participate with you, and to the Director, thank you so much. We are very much looking forward to embarking on this journey with you, and I think especially with two new chairs at the helm, there may be some interesting discussions in the days ahead. You know, before I get too far into anything I have to say, which is probably not that important, I would love to recognize the House members of the committee who are here. My Vice Chair, Dan Cullinane from the City of Boston. Christine Barber from Somerville. Randy Hunt from Sandwich. Matthew Muratori from Plymouth, Brian Murray from Milford, and Stephen Ultrino from Malden. Oh, and I see John Santiago from Boston joining us. Welcome. I have been watching sort of from afar as a member of the House for now 11 years. And having gone through Chapter 224 and then serving as vice chair of this committee many years ago, I am really excited to see the progress we have made, and I think we have a lot to be proud of here in Massachusetts. Not only are we prioritizing access to health care for all of our residents, and clearly we've done great work around that, but we are also making sure that accessibility includes an acknowledgement that cost can be a barrier. And I am really looking forward to working on that issue this session and to join with the Commission and CHIA on digging into the data and understanding better where those cost drivers are. So as we move forward both today and into the future, I look forward to a robust conversation. I'd like to build on the successes we have had. I think there are areas, as we know, from the data that's been collected and well analyzed, that there are areas we need to address. And I think there are areas now we have data understand that there are areas we don't understand. And so how do we better educate ourselves on what those access and cost issues are into the future. So I want to thank you very much again for including us today, and I look forward to the partnership.
Chair Friedman, would you
Thank you very much, Mr. Chair, and I want to echo the words of my co-chair. I'm also very excited to be part of this commission. I will take a moment to introduce my Senate colleagues. Senator President Emerita Chandler is our vice chair. Senator Hines from the western part of the state, representing the western part of the state. Senator Sear from the Cape and Islands, and Senator DiMacedo from the South Shore. Can I call you the South Shore? Plymouth, yeah. Right. Okay. I too am very happy to be here. I can't think of anything more important we can be doing right now than addressing healthcare and healthcare cost. And cost, for me, is how it affects accessibility and quality. And we have, as you said, Mr. Chair, made great strides in this state just in our ability to look at what we have and our willingness to sort of open the kimono and see where things are going and how well we're doing. And I really want to applaud everybody for that and for the openness and the discussions that we're going to have that are going to really help people, not only around cost, but as much around quality. And I believe if we can really look at those costs, we can understand what's working and what's not working. Where should our money go? Where should we say, you know, we tried, but we need to move on? So the information that you, Mr. Seltz, Mr. Auerbach, and Mr. Campbell are going to give us today is a key part of that, and I really thank you for coming and being part of this.
Thank you. So just to briefly go through how we're going to operate today and then where this all takes us. As I indicated, after I finish a few remarks, I'm going to turn this over to David Seltz, along with Ray Campbell and David Auerbach, to talk about where we've been. And then we will have testimony from the key players in our health system, our hospitals, our health plans, physician groups, the public, different aspects of the consumer groups. And then the Health Policy Commission will take all this, put together, and then we will have an official meeting on April 3rd, at which point we will vote on whether, and here's the options that the law gives us. The original, as I said, the original laws and the law that's currently in existence said that healthcare throughout the state should not grow by the growth more than the growth in our state income. Originally, that amount was pegged at 3.6%, which it continued for several years. Last year, for the first time, we had the authority to go down to 3.1. If the commission agreed with that, then that would become the new benchmark. If some reason we wanted to go back up beyond, closer to 3.6 or up to 3.6, we needed to return this to both of you and your committees, and ultimately you'll decide whether you agreed with that decision or not. And we have the same issue today, and that is that the law either asks us to be at 3.1%, or to have something between 3.1 and 3.6. As David and Selce and others will show us, we've been, as a state, been under and sometimes considerably under the benchmark. Overall, healthcare costs in the state have grown a little over 3.2%. Last year, it grew by 1.6. The other thing is, hopefully David Auerbach will talk about, is we continue in the last several years to be growing less rapidly than the country as a whole, and he will fill you in on that. So we will then, as I said, no decision will be made today. We will have a full discussion open to the public about whether we go to stay at 3.1 or do something independent of that. And I appreciate your comments, Chair Friedman, in terms of, we've always been very open and about, where we are. I don't want to pat us on the back, but I will. I think we in the state, thanks to the legislation that you've created, allows us to know more about what we do and what's going on than any other state. I go around the country and talk to I haven't been in every state talking about this, and a little envy. And how did you get there, they ask? I said, it all starts with data. And I really want to thank Ray and your team. It's understanding what's going on and having it made available. I would like to say hello officially to Senator Chandler, who has had the opportunity of listening to me and listening about this issue for many years. Would you like to say something? No, that's quite all right. I couldn't resist the opportunity of just saying hello. Okay, so I don't want to take any more time. Again, we will have, after these presentations, a number of groups and individuals have signed up. If there is anybody else who would like to sign up and make an official comment, our great assistant, Conley Osmeyer, is there, and please indicate to her that you would like to talk. So let me now turn this over to the Executive Director of the Health Policy Commission and my colleague since the beginning of this run, David Selce. David?
Great. Good morning, Mr. Chairman, esteemed members of the Health Policy Commission Board, honorable chairs and vice chairs of the Healthcare Financing Committee, and distinguished members. Welcome to the third annual hearing on the potential modification of the healthcare cost growth benchmark. As Chair Altman said, this is really a unique opportunity for the HPC board, the members of the legislature, and the public to meet and discuss our shared goals for addressing the high and rising costs of healthcare in the Commonwealth. I'm David Selce, the Executive Director of the Health Policy Commission. I'm pleased to be joined here today by Ray Campbell, the Executive Director of the Center for Health Information and Analysis, and David Auerbach, the Director of Research at the Health Policy Commission. We will also be joined a little bit in the presentation by Zhang from CHIA, who is the Senior Director of Research there. So for the first part of the meeting, we're going to do a presentation and really want to walk through these 7 questions. And so for members of the committee and board, we do have in your packets the full presentation to walk through. And this TV over here will be following along as well. We really want to have a data-informed foundation for today's conversation. And so the findings that we're going to present here today are largely taken from both CHIA and HPC cost trends reports, which are available to you and included as part of your packets here today and available online. But we also do have some new findings that we're very excited to present for the first time today. We really want this to be a conversation, so encourage HPC board members and members of the committee. Please stop us along the way, ask clarifying questions. Feel free to make comments as we go through this presentation. So the first section and question that we have in this agenda is, what is a healthcare cost growth benchmark and how is it set? And I think, Stuart Altman, you artfully and summarized a lot of this content, so I will move through these slides relatively quickly. Chapter 224 did establish this all-payer healthcare cost growth benchmark in law. Massachusetts was the first state to pass such a benchmark. We are not alone now in being a state that has one of these benchmarks. Both Delaware and Rhode Island have now adopted a very similar Massachusetts-style all-payer healthcare cost growth benchmarks in the subsequent years. As Chair Altman said, the law also established 2 new independent state agencies, the Health Policy Commission and the Center for Health Information and Analysis. The Health Policy Commission's role is really the policy hub and partnered with the data hub at SHIA. We have a lot of different responsibilities, which I won't walk through here today, but just to say that we have a role both in monitoring and enforcing the benchmark, but also in tracking changes to market consolidations and hospital mergers in the Commonwealth. We have a role in certifying accountable care organizations. We have a role in making investments in innovation in the healthcare industry, as well as a role in providing patient protection through our Office of Patient Protection for rights of patients who are denied services by their insurance companies. SHIA, as Ray will talk about a little bit later, also has a lot of responsibilities in collecting and aggregating the data that really provides the foundation for all of the work that we do and understanding the healthcare system performance in Massachusetts. This slide, which is slide 7, just summarizes the benchmark. It repeats points that the chair has already made. I would note that the Commission does have the authority to potentially require a performance improvement plan for certain healthcare providers or health plans that have excessive healthcare spending growth. This is an authority that we have not exercised to date, but is a big part of our annual review process to hold individual health plans and providers accountable to the benchmark as will be discussed today. As mentioned, this benchmark is indexed to the long-term growth of the state's economy. I will move quickly through this, other than to say that there is a process every year by which that measure is annually set. It has been set at 3.6% every year since the passage of the law. And as on the next slide, everything is then kind of indexed to that. So on slide number 9, you can see in the graphic here, as Chair Altman said, for the first few years, the benchmark was set at 3.6%. We are in the middle 5 years where there is some latitude for the Commission to set it between 3.1 and 3.6. But as the Chair said, 3.1 is the default and would require an additional process if it was set somewhere in between those two numbers. Starting in years 10, the default moves back to equal the long-term economic growth rate, but the Commission's discretion to set it at a different rate is unlimited at that point, but still subject to legislative review. This next slide just talks about the process that is laid out here today. And as the chair said, a potential for further process if the board did decide to set it at a number other than 3.1%. But as contemplated in the law, really important to have the collaboration and participation of the Joint Committee on Healthcare Financing in this process. And so, again, thank you all for being here. And then finally, a slide just on the timeline where we do expect to deliberate on this question at the next board meeting on April 3rd. Finally, this nice little wheel just illustrates that this is an annual process that includes many steps across the calendar. This is really the first thing in the calendar is setting the benchmark, and then SHIA will collect data, we'll understand our performance against that benchmark, we hold annual cost trends hearings in the fall, and ultimately the Health Policy Commission will issue an annual report with potential policy recommendations. So all of this feeds into an annual process with many different points for public participation along the way. So with that as just a background on the overview and the law, recognizing I moved through that quickly. If there are questions, happy to entertain any of them at this time. But otherwise, I think we can move right into the depth of the presentation. All right, great. Seeing none, I'm going to turn it over to our Director of Research and Cost Trends, David Auerbach, who will walk us through some findings about our performance as a state, comparisons to the United States, where we see some of these cost drivers, why does addressing healthcare costs matter, and then finally, some conclusions around where we go next in terms of some recommendations from the Commission. So with that, I'm going to turn it over to David.
Great. All right. Thank you, David. Good afternoon, everyone. Okay. So in the first section, how has our performance been against the benchmark? And as Stuart mentioned, in the very last year, our growth as a state was 1.6%. That was the lowest of the 5 years, as you see here. And that brings the average for the cumulative for these 5 performance years to 3.2% health spending growth per person per year. And also, as Stuart noted, that growth puts us below the national average. You can see here from 2000 to 2009, healthcare costs in Massachusetts grew faster than the national average. And since then, we have been below in every single year by roughly 1%. Now, that healthcare spending is made up of not just commercial spending, but it combines Medicare, Mass Health, and commercial spending, as you see in the pie here. Each of those pieces are roughly equal amounts of money in the overall market. But you can see from 2016 to 17, they grew at somewhat different rates. Growth in the commercial market was 3.1%, faster than in Medicare, 1.9%, and in Mass Health, spending actually declined a little bit in 2017. That's partly because of enrollment drops. And that makes up the total pie of $61 billion in healthcare spending in the state. And when we look at what areas of care are responsible for most of that spending growth, we can see, as we have been in the last few years, that pharmacy and hospital outpatient are the fastest growing categories. And we've had a lot of attention on these areas, which we'll talk about more, faster than hospital inpatient or physician care or other categories of care. Okay. So where does that put us in a national context compared to the rest of the country? This graph is showing healthcare spending per capita in all the 50 states. And this is in 2014, the last year for which we have data like this. CMS puts out this data every 5 years, so pretty soon we'll get a 2019 update. But as of 2014, we were the second highest cost state in the country after Alaska. Since 2014, we have grown more slowly, so this has come down a bit, but we're still probably on that end of the scale for sure. Now, some people might argue we have a higher income. Maybe that's okay. This next graph is showing state-level income on the x-axis against state-level healthcare spending on the y-axis. Each of the 50 states are represented here. And you see that, yes, there's a relationship. The higher income states do have higher healthcare spending. That's the yellow line. But even accounting for that, we are still high. If you look at us in the neighborhood of Connecticut, New Jersey, Maryland, Hawaii, other high-income states, we are still far above them in terms of our healthcare spending per person.
So let me just rephrase then for you. So while our spending has decreased and we're underneath the cap, we're starting from a very high rate of expense in the Commonwealth of Massachusetts spending.
That's right.
So
That's
I
right.
wouldn't exactly do a victory lap.
Right. We've come down a little bit, but we have a far way to go to get to that national average. And we can think about, okay, we've got higher than average spending. Where is that coming from? What accounts for most of our excess spending above the national average? This graph is showing that $854 per person per year is coming in the area of hospital care. Long-term care and home health is an even bigger contributor to our higher costs compared to the national average. And a smaller contributor is in professional services, mostly physician spending. So we know that a lot of that excess cost is in hospitals. We can drill down even further and look at where do we use more care and where is that cost coming from. This is a slide about use of care, and we're comparing us to the national average, and we find that we have 9% more inpatient discharges, hospitalizations, than the rest of the country, 45% more hospital outpatient visits, 11% more ED visits, and we are 18% more likely after someone's been in the hospital to then go to a nursing home or a skilled nursing facility after that hospital episode. So we have more utilization in these high-cost areas of care. We also use more intense care even for routine kinds of visits, such as a typical Medicare patient going to see their doctor. In Massachusetts, 1 out of 5 of such visits take place in a hospital outpatient department, compared to 1 out of 10 in the rest of the country. Or if someone just has a routine hospitalization, in Massachusetts, 42% of those take place in a teaching hospital, which get paid more by Medicare. That adds to our higher costs, compared to 18% in the rest of the country. And as many of us know and we talk about often, we have a higher rate of readmission. Once somebody's been to the hospital, this is for Medicare patients specifically, in Massachusetts, the second highest rate of being readmitted to that hospital within 30 days. Most of the country is going down on that metric, and that's the blue line, but we are going up in the yellow and in the orange, which is the all-payer version of that measure. Okay. So part of our high costs is we use more expensive care, and we use care in higher cost settings. Now we can look more at growth. We know that our growth has been a little lower than the national average, but there's still growth in healthcare spending, and what is driving that growth? This page is, slide 26 is showing from the insurer point of view, when we ask them, what are your cost drivers over the last few years? These are the 3 largest Massachusetts insurers represented here, and they were able to break down their spending among their enrollees into price, utilization, use of care, and provider service mix, which is a measure of the intensity of care. And they find that more than half of total cost growth is price, and that's what you see in the left bars over there. We find this when we look in other categories of care specifically as well. The next slide is showing hospital care for people with commercial or private insurance. Now, we noticed from 2014 to 2016, commercial patients actually are using less hospital care. The number of hospital discharges declined 7% per 1,000 members. But we didn't save money. Total spending went up 7% for the same population, and why is that? You see in the blue, it's mostly because the price of hospital care increased for the same type of care. And you also see an increase in the acuity of that care. Those led to a spending increase despite the volume decline. We see something similar in the ED. Next slide is showing that number of ED visits per person in the gray on the bottom has been relatively flat over these years, about the same. Yet spending per member increased 12%, spending per visit increased 11%, and that's mostly because of price increases, which you see in the orange there. Price for the same visit. We also look at pharmaceutical prices, which we all know are increasing. And to do that, we're highlighting a deep dive on people who have diabetes and need insulin. Okay, so here we're analyzing our all-payer claims database from 2014 to 16 and focusing on this population specifically. Now, we know that prices have continued to increase in 2017, 18, and 19, but our data here is only going up through 16. So the next few slides are going to highlight this population. What you see on slide 30 is that the price increase for insulin has risen 50% between 2013 and 2016 for the same drugs, same product. That amounts to a daily cost rising from about $9 a day to $13, and an annual cost from $3,000 per year to $4,700 per year for these patients. When we look at total spending for these patients, you see an increase from $13,000 to $17,000 over this time period. Spending on insulin alone is that top bank in the orange, and that has increased as a portion of their total cost. And non-insulin drugs, when you add all their prescriptions together, that accounts for more than half of their total cost, about $9,000 per year for this population. Now, that's the amount that of total spending, including what people pay out of pocket and what their insurers pay. If we focus on just the part that people pay out of pocket, how much is that? And focus on the people on the high end who are using a lot of insulin and have a lot of out-of-pocket costs. This is just out-of-pocket spending for insulin, and we see that about 5% of the population paid more than $750 per year. And that portion paying that level of cost has risen. The blue line, the blue bars are showing 2016. That's up over 6%, paying that level of cost, more than $1,000 for, on average, for this portion of the population out of pocket. And we know that leads to a lot of people foregoing using drugs or using less than they actually need. Okay, so let's pause there before we get to the next section, see if there are any questions or reactions. Yeah.
I just want to make sure I understand this. So the unit price has gone up, and does that include
Right.
pharmaceuticals in that? I mean, that includes drugs and, okay, any,
Yes, that is. We didn't show the unit price, the price per unit, but it's people take on average 60 units of insulin a day. That is just the price of insulin itself. There are several versions of it, but if you average them together.
okay, but in terms of just on slide 26, that unit price number includes medications and stuff.
Right. So the information from the health plans where we broke that out and said that price was a major driver, that does include price increases for pharmaceuticals, and is probably a large portion of that.
Okay. And then just the other question I have, so it looks like insulin has gone up quite a bit. Has something changed in insulin that's caused this price to go up?
Biologically, no, not that we know of. It's purely a price increase.
Okay, great. Just, thank you.
You're using insulin as an example, or is it the best example of this?
We're using it as an example. We're sort of following something that's been very prominent for a specific population that needs this to survive. This is not atypical. We could have looked at a lot of other examples, but we picked this one because there's a sizable population that's affected by it, and it's happening everywhere in the country.
Thank you, Mr. Chairman. I'm looking at hospital outpatient. I mean, you're doing the deep dive into insulin to show sort of the pharmacy issue, right? But do we have any data to show what is driving that? Is it a shifting of services from inpatient to outpatient? And we saw that on a couple different slides, 17 and 22, I believe. Do we have data to show there's a relationship there?
That's a great question. We have looked at that in a number of ways. We do see some services shifting from inpatient to outpatient. We also see some services shifting from some things could be handled in a regular physician's office, moving to outpatient, where you might then have a facility fee and pay a higher cost for the same visit. So it's going both ways. And we haven't been able to exactly tease out the contributions of all those shifts to what is leading to that outpatient growth. But we continue to delve into this, and we'll do it this year as well.
Just to follow up,
Yeah.
so I would assume that if you're shifting from inpatient to outpatient, then there's a cost savings there, right? But obviously, the other shift is
Right.
critically important from a cost driver.
Mm-hmm.
Do we have any sense of the types of services that are being shifted from an office visit to outpatient, and can we extrapolate any reasons for that?
We have some sense of it. A lot of the shifting from offices to outpatient are even just typical visits or images or procedures or tests, things like that. If you'd want to know more specifics, well, we should chat about that after. We've published in previous cost trends reports, looked at certain procedures and tried to isolate the relative volume in either setting. But these are sort of narrow examples, and we don't have the full overall picture to be able to parse it as we would like at this point.
I would just add two thoughts to that. One is absolutely we have seen some surgeries that have moved from what would typically be an inpatient stay to an outpatient stay, and that is cost reducing for that procedure. At the same time, though, we did find that and this was a couple of years ago, but for some surgeries that were moving from inpatient to outpatient, what was left in the inpatient side, actually the prices went up to such a degree that there wasn't actually savings from the shift. Now, what that means is that whatever surgeries were left, they had a 10% price increase. So the total amount of money that was going for that pretty much stayed the same, even as some of that care was shifting to a different setting. So that's why price is so important here. And we do see that even where there are utilization shifts, if the price of what's remaining then increases by 15-20%, you haven't really saved any money in terms of a total revenue situation. The second thing I would add in terms of the other shift, which is from physician to outpatient, that can also be driven by just acquisition of these physician practices by these big hospital systems. And they can license these physician practices as hospital outpatient departments. And that may be nothing has changed in terms of the care that they're providing. Nothing has changed in terms of their facility or even the doctors that are providing those services. But the shift in licensure from a physician office to the hospital outpatient department is cost increasing because they can charge an additional facility fee under the hospital license. So these are important shifts, and how billing occurs is important. So it may not be that patients are necessarily even shifting. It may be that some of these physician practices are being acquired and purchased and part of these bigger hospital health systems.
David, you, both of you alluded to the fact that when you compare Massachusetts to other parts of the United States, we tend to disproportionately use outpatient departments of hospitals, where in other parts of the country, they are still going to the physician's office and so on. So it's not only the trend that David talked about, but it's one of the reasons why it turns out why we're more expensive. So it's not that we're using more care than other parts of the country, it's just where we're getting that care.
Yeah, sure.
And pricing is perfect. Now we're on. I can stop yelling. Thank you very much. And so what I was mentioning, that the diabetes statistics are very alarming, and as we look at national projections, that's only likely to increase. And as we get into the future of what's likely to happen with insulin pricing, are there any geographic stats available or geographic breakdown for Massachusetts where we might be seeing any hotspots or where diabetes is increasing at a more rapid rate than elsewhere?
We haven't done that analysis, but we can.
Okay.
And we will and could be able to provide that for the committee and for you.
Thank you very much.
Thank you, Mr. Chairman. This is my fifth or so year on the committee, and the last two times you spoke, and I think the chair was leading to this, was maybe we're shifting where we're getting our services, but your concern was that scheduling may be an issue. More people are going to emergency rooms or Doctors Express or whatever you call them, because most primary cares work 8:30 to 5. Most people will go to the emergency room after work maybe, or middle of the night. And my first question is, do you still see that this year? And my second question is, do you see the number of people going into primary care, this is what I'm hearing, going down because many medical students are going into specialty areas where they make more? Is that a trend that you're seeing, or am I incorrect?
So for your first question, we absolutely still see a trend of a significant proportion of the population who is using the emergency department for non-emergency conditions. The latest survey from CHIA was about 1 in 3 Massachusetts residents, their last visit or family's visit to an ED was for what they characterized as a non-emergency situation. And one of the primary reasons that they cite for why they use the emergency department is after-hours access and access to primary care. Now, we do know that many primary care practices are starting to do more expanded hours or having open scheduling. Certainly, we've documented the rise of urgent care centers, which are a potential other more flexible service source. But absolutely, that trend continues and is an opportunity if we can increase access to primary care and to other appropriate settings to reduce unnecessary ED utilization and save money. I think the second question around kind of trends in medical education around primary care, I'm going to look to my Health Policy Commission board maybe to speak more to that issue. I don't know, Stuart, if you have a sense of that today.
Would you like to comment? to weigh in if you want. David, go ahead.
Yes. Well, I could say that, yes, the number of physicians choosing primary care, family practice, or internal medicine, and then going into primary care, it is not going up. It's low, and it drops a little bit every year. At the same time, the number of nurse practitioners completing school and going to primary care is growing very rapidly. And, it's projected that it's probably going to double in about 10 years. So that's an important factor to consider as well.
Yes, sir.
Thank you, Mr. Chairman. So on slide 22, it mentions how Massachusetts uses high-cost settings of care to a much greater degree. I think you said twice as often. And how much of that can be attributed to the fact that we require a referral from a primary care physician in order for someone on Mass Health to go into like an urgent care setting?
I don't think that's a large player in these statistics here.
Do other states require such a referral?
I'm not sure about that.
I don't know that we know.
Okay, thanks.
Yes, sir.
Thank you, Mr. Chairman. Two questions. One, you mentioned since 2014 that commercial customers are considered less care but are not seeing the savings. Can you talk about what does that look like in the public payer perspective? And then you can talk a little bit more about this licensure piece. I presume you're talking about licensure from the Department of Public Health. But just a little clarification on those various tiers. That was something that's an interesting point to me. I'd like to hear more about that. Thank you.
Yep.
On the first question, right, the decline in hospital use among commercial patients that we showed. Now, interestingly, that is not, we haven't seen that among Mass Health or Medicare. It's really just a phenomenon among the commercially insured. And so that does create a slight shift in the mix of patients that hospitals see. They're having more and more of a public payer mix. That's just happening. But then you see that those prices for those commercial folks are rising, perhaps offsetting what would be a revenue loss otherwise. Licensure, could you repeat the, yes. Do you want to, I'm not sure I have a comment on that.
This issue in terms of how different billing can occur based on the licensure of different facilities. This has been an issue that we've been tracking for some time. And when we receive notices of market changes where physician practices are being acquired by these hospital-based systems, we do ask, do they intend to charge at the higher hospital outpatient rates with that additional facility fee? And in some cases, providers have made commitments not to do that. In other cases, once they are part of a hospital-based system, they can change their billing practices accordingly. Now, there are new federal rules that have put limits on the ability of health systems to do this and to bill more for Medicare. So there was a law that was passed, or a regulation, that essentially said unless this facility or the doctor's office is within 250 yards of the hospital, then they cannot be licensed under the hospital license in the future. And so, again, think of just your standard doctor's office. And I want to reiterate that this can be very confusing for patients who think that they're just going to a doctor's office, but because it's licensed under the hospital, they may receive an additional bill that is basically overhead for the hospital, even though, for all intents and purposes, that resident thinks that they're just going to their doctor's office. And so while the federal guidelines have prevented this moving forward, it did grandfather in everyone existing who had this kind of other status. We at the Health Policy Commission have made recommendations in our cost trends reports to address this issue, both in terms of providing a lot more transparency for patients, that when they're going to these facilities that may charge this higher fee, that they should know about it in advance of getting care and services. And secondly, that there may be and should be some services where this additional charge is just not warranted. And so, for example, a routine, regular physical office visit is twice as expensive when it's billed under a hospital outpatient as when it's billed under a physician license. And when we think about one of the most basic healthcare services, why would it be allowed to be twice as more expensive? So there are policies that try to say, for some basic services, maybe we should not even allow this additional charge.
And I do want to, I'm glad this came up, because one of the very important issue that are going to be before both of your committees is the issue of surprise billing. And this relates very much to this issue where a patient goes in to what they thought was a normal physician visit that they previously had been getting from a physician's office, and they wind up getting two bills. One bill is the normal bill that they always got, and then maybe a week or two later, they get a much bigger bill, which is related to these facility fees. And sometimes the insurance companies say, well, if you're out of net, we're not paying that, and all of a sudden the patient winds up. This is a very contentious area that's being addressed all over the United States and is being addressed in Washington, and it is right before both of your committees. And and we've made some recommendations that there should be some really serious look at how we protect patients. So, yes, sir.
Question on slide 21, where you talk about hospital care and long-term care expenses. You have long-term care and home health care expenses at $945 combined. Do you know what the percentage of that is? How much of that is long-term and how much of that is home health?
Yes. I believe we do have that breakdown. I don't have it on this slide. It's probably more of the long-term care, although we are a very high user of home health care. And since 2014, I think that gap has closed a little bit, but I would say it's a significant contributor from both. But we could get you the breakdown. Yeah.
Thank you, Mr. Chairman. I refer to slide 14. When we had these discussions in the last couple of years, one of the reasons, significant reason that was given for the bump in 2013 to 2015 were the new hepatitis C drugs that came out, which were very expensive, but very effective. And so my question is related to that since they actually cure hepatitis C, would you expect as time goes on that we would see a bell curve in the cost of that drug, or are we seeing some input for demand from that, perhaps coming from the opiate crisis we're dealing with, or other issues that might keep that cost high?
So I'm happy to speak to this. And I think it is important when we look at this benchmark performance slide to note that there are 2 years that we were above the benchmark, and there are really important contextual reasons why. One, in one of these year periods was a time when enrollment in the connector was not working as well as it is today. And in terms of ensuring that we maintain universal coverage, certain residents were put on temporary coverage in the Medicaid program, and that did have an impact on spending in that year, but consistent with our values to kind of maintain a high universal coverage. The second, in the other 2-year period, as you mentioned, was the introduction of Sovaldi, which is the hepatitis C cure. And I would note that but for the introduction of Sovaldi, we would have been below the benchmark in that year. That was such a significant driver. However, what we do know in terms of two things. One is that when Sovaldi was introduced, it did not have a competitor, and so it was first introduced at a very high list price. Since that time, there have been a number of competitor drugs that have been introduced into the market, and that has driven down the unit price of that drug. So what was more of a $100,000 list price has now come down, and I think the Secretary can speak to, in the MassHealth case, they were quite successful in being able to compete on the drug price. Before I turn to the Secretary, I just would also say, in terms of the long-term savings that we do think will happen because this is a curative drug, I think that the timeline on which what we'll see those savings is not, I don't know if maybe my colleague can speak to that, but is a longer horizon and may provide savings to the Medicare program. So I don't know, David, if you...
I don't, right, but I don't think we're going to be seeing that in numbers like this, making a big difference.
So if I can just address the drug question for a second. So when Sovaldi came onto the market on the Medicaid program, it was $55,000 per member per unit. And when competition was entered into the market with 2 other drugs, MassHealth was able to enter into competitive negotiations with the three drugs to reduce the cost from $55,000 per member per unit to $14,000 per member per unit. And in so doing, we were able to also ensure universal access across the Medicaid program. It's a great example that when there's competition in the drugs, you actually can negotiate, at least in the Medicaid program, reasonable rates. The cost currently is now that the drugs coming onto market have no competition. So the ability to negotiate fair and reasonable rates is significantly compromised. In fact, you have no choice. I also would like to go back and address the urgent care question, if I could, or comment. So I'd like to clarify, because there seems to be some misunderstanding about what we do or do not do in the Medicaid program around urgent care. I'd also like to remind everyone that there is no common definition of what an urgent care is, nor do most urgent care centers in the Commonwealth of Massachusetts do anything when it comes to behavioral health, oral health, or a whole bunch of specialty services. 1. 2, we've made a commitment to actually define what urgent care is and to establish regulations, what they should be in Massachusetts. We do actually currently license minute clinics, or what we know in Massachusetts is minute clinics. And 3, it's only half of the Medicaid program requires a referral. And the reason we do is because we did a major restructuring of the Medicaid program into trying to create accountable care organizations and to trying to provide integrated care for individuals. And it is in that program that in the ACOs, there is actually no referral networks. Referrals for urgent care. They just have to be part of the ACO family.
Thank you, Mr. Chairman. And thank you for the great presentation. You may have answered this in your previous response. I was curious on slide 14, which I think we're on right now. Much of the presentation has to do with the reasons why costs remain high, but the precipitous decline from almost 5% just 2 or 3 years ago down to 1.6. I mean, what would you describe as the leading factors?
Yeah, that's a good question. There's so many different things that combine to go into these numbers that it's hard to really pick a single cause. It's helpful to, if we have a version of this somewhere where it shows for commercial and for MassHealth and for Medicare, they're really different situations, different scenarios that you have. The commercial spending growth has been sort of 2-3%-ish, fairly constant across that time. And what varies, what's pushing that total benchmark up and down is often things like enrollment. The enrollment in MassHealth fluctuates up and down sometimes. The Medicare spending growth is usually fairly low, but that also has enrollment increases as our population ages. Absent something like a Sovaldi or a big chunk of people coming on in 2014, the ACA expanded eligibility in a lot of cases. Absent those, we get our 1.6 last year with sort of a, nothing remarkable happening, but just sort of vanilla cost growth, although there was some decline in the MassHealth enrollment. So it's hard to really put it to one cause.
And I would just add, on MassHealth, the per member growth was, I think, around 3%. So there was enrollment fluctuations can make a difference in terms of the total spending there, and I don't think that's necessarily something that we should expect for the future. And certainly the continued pressures on that program will continue. The one thing I would just add to Dr. Auerbach's comments is that on slide, let's see, as shown here, where we have higher utilization of hospitals, emergency departments, and hospital outpatient visits. This is, again, talking about higher utilization of all of these different types of services and how much more we do in Massachusetts compared to the country. These numbers have all actually come down. So in 2009, these differences were even greater between Massachusetts and the United States. So it does appear that we are making some progress in closing some of these gaps, but it is slow progress.
Yes, thank you, Mr. Chairman. David, on slide 16, when we mentioned Medicare's growth, I'm just trying to understand, does that include B, D, or Medicare Advantage plus out-of-pockets?
Yes, they're all included in this Medicare.
But does not include gap insurance. We left that out.
Right, but it doesn't include
Is that
Medigap.
correct?
That's
yeah.
Right.
On the slides where we went through type 2 diabetes, did we also include related issues that a type 2 diabetic would go through? For example, high blood pressure. Is that cost also built in? And when you look at type 2 diabetes, did you compare that to the growth rate? The cost may be different, but the growth rate in the other major chronic conditions? Thank you.
Good. Well, first of all, I'll say that this isn't just type 2 diabetes, but this is the defined population that we're looking at here is anybody who's a regular insulin user. So it is people with type 1 and type 2. And within that population, right, you're seeing in one chart we showed their total cost from all sources. So it's all included there. Everything they spend money on. In other work, we have looked at other populations, people with hypertension or and we can show you more about that. This was a deep dive on a narrowly defined population that is affected by the insulin prices, especially. Okay.
Stuart,
yeah.
Two quick things. To Representative Hunt's question about the hepatitis C drugs, I think we should note that although that's a special and famous case, it's coming in many forms. The immunotherapies, CAR T for cancer, the FDA just approved for teenage eczema drugs that's $37,000 a year. So this is a pattern, not just an instance. I have a technical question. Really back to your opening remarks, David. I should have asked this a while ago, and I'm embarrassed to have to ask it now after 3 years on a commission. Under the law, that 3.6% that we're all referring to, which has been stable for years, that could change, right? The benchmark could fall. If we have a recession, the predicted state gross product could go down, in which case our authority isn't about 3.1%. It's about whatever that number is minus 0.5%, right?
So, yeah, it is indexed to this figure of the long-term economic growth, but I would say that figure is intended to be adjusted for big ups and big downs. So it is intended to be something that is stable and long-term. And so it would not be something where if there was a recession, we would necessarily see that go down. But if there was a structural change in terms of the Massachusetts economy, either a sense of greater growth or lower growth, that would change the measure by which everything is indexed to. I would say so the process by which that figure is set is by Administration and Finance and the two Ways and Means Committees through the consensus revenue process. And I would say, having reviewed some of the long-term economic estimates, they all generally fall into the 3.5 to 3.7 range and have been pretty consistent over the last couple of years.
So in our multi-year planning, we shouldn't anticipate that number will change?
There would need to be a compelling reason for that to change.
So maybe we should move on because obviously what we're really trying to figure out is where we're going. So
Great.
What crystal ball are you prepared to give us?
Where are we going? That's right. Okay. So a couple slides on where we might be going, and then we'll talk about affordability a bit. Just for these next two, we're showing CMS, which is the Center for Medicare and Medicaid Services, their national projections of healthcare spending, which just came out recently. And the thing to note here is that you can see annual growth rates. They've got projected out to the year 2027. And they expect growth in healthcare costs to be in sort of the 5-6% range across all of these services in the future. So that's a little higher than they have been in the last several years. It's just something to note. You can see the very high variability in drug costs with the Sovaldi bump in 2014 there. And here they are breaking down those cost projections into the components: utilization, price, population growth, the age and sex of the population. And the thing to note here is the price is the yellow. That is projected to be a large chunk, the biggest single component in 20 to 27 of that expected growth. Okay. So let's move into the next section of affordability and why all this really matters. And I'll give a few slides here, and then we'll shift to Ray. So here's one reason this matters. You can see here cumulative growth from the year 2000 to 2017 in several economic indicators. You can see price inflation grew 45% in total over these 17 years. Personal income grew 75%. And far above that are what people pay for health care. And here we're looking at premiums for people who get insurance through their employers. Total family premiums grew 187% over this time. The employee contribution to that premium, what people pay out of their paychecks, has grown even faster, 269%, suggesting that people are paying more and more of a percentage of that premium, which is true. Okay. And as we talk about premiums, this slide shows well that it's true that here we have Massachusetts employer premiums in the orange up on top there. You can see that we are above the national average, which is the blue. But for our large employers, we have come a little bit towards that national average that due to our lower growth that we showed earlier. Now our premiums for large employers, for people who work for large employers, are 10th highest in the country. Although for small employers, that has spiked up recently, and those are the second highest in the country. And this is in contrast to our Health Connector, which has premiums that are the second lowest in the country, shown below there on the bottom. But most people are getting their insurance through their employer, and here we focus on out-of-pocket spending with that insurance, plus the employee contribution to that premium just for middle-income residents of Massachusetts, income between 139% and 500 of the poverty level. And when you look at us in the orange compared to the rest of the country, we are paying more. The combined average cost for a family is $7,600 in the last 2 years. And note especially that 90th percentile, that orange dot up there, that means that 10% of Massachusetts families are paying more than $16,000 a year when you add up their out-of-pocket costs and the employee portion of their premium that comes out of their paycheck. And this is for somebody earning, roughly $60,000, $70,000 a year. That's a huge burden. And so let's learn more about what that burden really means for families. Sure, okay. And we're gonna hear from some analysis chiefs then.
Thank you, David. Honorable chairs, members of the commission, senators and representatives, it's my pleasure to be here today to first offer some introductory comments about affordability before turning things over to CHIA's Senior Director of Research, Zi Zhang. CHIA, as you know, measures the Massachusetts healthcare system. We have a lot of different tools for doing that. We have an all-payer claims database that we use for certain purposes. For purposes of measuring total healthcare expenditure, we actually use health plan aggregate reports because they're a lot faster than waiting for claims data to accumulate. But the truth is neither claims data nor aggregate data can get at issues of motivation, and for that we need survey data. And so CHIA does 2 very large surveys of the Massachusetts population, one of households, one of employers. And so we're here today to share with you a little bit of information about from CHIA's 2017 household survey, what we learned about affordability and a deeper dive that we'll be releasing shortly on affordability issues. Just for context, CHIA's annual report, which uses aggregate health plan data, showed that although the total growth in healthcare expenditures in the state was only 1.6%, commercial insurance increased by 3.1%, and there were other indicators that, the top line number, although that's satisfactory, some of the numbers underneath it are less favorable, such as fully insured premiums grew by 4.9% in 2017. That's an acceleration from the 2% growth rate the year before. Member cost sharing grew by 5.7%, which is faster than inflation, wage growth, and premium growth. And furthermore, we saw more than 28% of the population is enrolled in high-deductible health plans. And so that has a significant impact on costs in the market. So because of that, she is very interested in issues of affordability, and so we have used our health insurance survey to try to look at some of these challenges that confront us. Dr. Zhang will be talking about this in more detail, but we've done an analysis to look at the issue of affordability, particularly through the lens of understanding how many people in Massachusetts have problems paying family medical bills, how many families in Massachusetts have medical debt, how many people had unmet health care needs due to cost considerations, and how many families spend a very high percentage of their income on out-of-pocket costs. So those are issues that we tried to dig into with our survey data, and I'll turn things over to Dr. Zhang to talk in more detail.
Issues are complex. As Ray just mentioned, we look at these issues from 4 different aspects in our survey. So in 2017, about 43% of the residents reported having a affordability issue in the past 12 months, the top orange bar. And then the next orange bar is about percentage of residents had more than one affordability issues. We're talking about 1 out of 5 residents. And if we were to look at these individual affordability measures, those dark blue bars, so it's about a quarter of the resident had unmet health care needs due to cost. They could be just have concerns about cost sharing, or their health plan don't cover certain services. And then 1 in 6 had a family medical debt, and another 1 in 6 had a high family spending on out-of-pocket health care expenditure. And this is based on a out-of-pocket in relation to household income ratio, and we used the Commonwealth Fund cutoff. So for families with household income below 200 federal poverty level, we used a 5% cutoff, and then for the relatively well-off family, we used a 10% cutoff. So what we found in our analysis is that healthcare affordability issues affect all social demographic and health status groups in the Commonwealth. No group is immune. Certain population, however, thank you, Ray, had a higher level of affordability issues than others. So in the next 2 slides, actually, I want to highlight some of the results by residents' health status and then family income. So residents in fair poor health, represented in light blue bars, typically have more health care needs than those in good, very good, or excellent health, the dark blue bars. And what we found is that the folks with self-reported fair or poor health had a significantly higher rate of affordability issues than those in better health. So we're talking about 58% versus 36%, the first pair of bars. And this gap is even larger when we look at those with multiple affordability issues. So it's 30% versus 12%. The second pair of bars. So for family income, how we advance? So for family income, we are presenting 3 income group. The low-income residents, those with family income less than 139 FPL. The light blue bars, these residents are more likely to be covered by Mass Health. And then moderate income residents, defined as family income between 139 to less than 300 FPL, the dark blue bars. And then residents with family income at 300 or higher, the gray bars. As you can see, 50% of the low income resident and 56% of the moderate income residents reported at least one healthcare affordability issue. And while insured residents with family income at or above 300 FPL had a relatively low rate, but healthcare affordability is still significant for more than a third of them. So we are currently in the process of finalizing our research report detailing the findings of this analysis. We hope to have it ready for public release in the next month or so. I just want to make a quick comment of surprise medical bill, and it's something that, as we are doing the survey, we continue to refine questions on affordability, and we are just in the process of pre-testing some questions on surprise medical bill for the 2019 survey, and we hope to have some data available to report soon. Yeah. Thank you.
So I'm assuming you can break out the under 139%. 139% of the FPL by carrier? Because Medicaid has no copays, it'd be sort of interesting to look at that versus people who are not eligible for Medicaid because of the congressional prohibition for individuals who've been in the country for less than 5 years.
Yeah,
one example.
Yeah, we will look further into that. So one of the caveat is that survey data is a little imprecise in terms of specific plans that people report, particularly with some of the Medicaid HMOs. People sometimes get confused whether it's a private plan or public plan. But we could look into that as well.
Yeah.
All right, so we just have a few more slides to go. Over the next decade. What we did here is we compared what if we actually could keep our healthcare spending growth to the 3.1%, which is the target that we're discussing today. And what would that mean over the long term in terms of potential avoided spending to the Commonwealth? And this really is just a thought exercise. Of course, our benchmark does not work to set a 3.1% for all of these individual categories. It is 3.1% on everything. But nonetheless, I wanted to try to just illustrate how much billions of dollars can be avoided by having a lower growth rate when it comes to healthcare spending. So we estimate total cumulative of $55 billion if you compare our performance at 3.1% versus the national projections. And this makes a real difference in terms of residents' affordability and the state budget. And so David will just talk about some of our findings here about what the magnitude is of the savings if we can hold to the 3.1%.
Sure. These are just some statistics that arise from that modeling. And this is just on the commercial portion of the market, that $24 billion in savings that we would have. So if you look, for example, just at 2027, the last year in that projection, total healthcare spending, actually this is THCE, would be $86 billion instead of $99 billion. $12.6 billion lower total spending in the state on healthcare than you would have otherwise, and that's a 14% reduction. If you look at just family premiums in that year, 2027, they would be $27,000 for a family for a year instead of $31,500 if we got that 3.1% growth rate. If you add up over the total of those 10 years, how much more money would be coming back to workers in terms of take-home pay to spend on things they need? $6,600 more. And there would be additional $1.24 billion collected in state income tax revenue from that amount of money not spent on employer health insurance, but coming home to people and take-home wages, and that is having the 5% tax rate. So those are just some of the benefits that would come from keeping that cost growth at 3.1%.
So finally, what can we do to help ensure that that 3.1% is achieved in the long term and potentially, hopefully, even lower than 3.1%? We and the Health Policy Commission have annual reports. You have a copy with you. There is 11 policy recommendations included in that report to help continue our progress in this effort. You can see the topic areas here. I won't walk through them now. They are included in the report in detail. And finally, one last thing, which is also in your packets, is last year we actually tried to do some modeling to say if we could make some progress in some of these areas that we've already mentioned today. Areas like if we were able to reduce unnecessary utilization of the emergency department, if we were able to actually make progress in reducing hospital readmissions, if we were able to reduce the growth in prescription drug prices, what could we achieve in terms of real savings? And so we modeled 7 different scenarios, and again, a total savings of billions of dollars, almost $5 billion in the next 5 years, if we could make progress in some of these areas. Again, these are intended to provide an illustration of that, yes, there is still tremendous opportunity for us to achieve savings in the healthcare system and to lower that growth rate in the long term, but does require continued action and urgency, both from policymakers and market participants. So with that, I'm willing to, I will stop the presentation and happy to take final questions from the board and the committee.
Yes, please.
Mr. Chairman, through you to David Seltz. From your experience, which of these 7 different scenarios has the best chance of making the savings? What would you advise us?
Well, I think of these 7 scenarios, I think there are places where the healthcare system alone could make a lot of progress. And so certainly an area as shown here like hospital readmissions, that is a huge amount of spending and money for residents. And if we could actually change that, that would be provide a lot of savings. Unfortunately, our healthcare system has just moved in the opposite direction, and we've actually gotten worse in terms of hospital readmissions. But certainly, as we continue to see organizations move into accountable care organizations and take risk-based contracts, they do and should have an incentive to think about the care of those patients after they leave the hospital, to have more integrated care in the community and in the home to be able to prevent these readmissions. So we hope and hypothesize that with further adoption of different payment models that hospitals and health systems will really be incentivized to do more on something like this. As an alternative and just as a contrast, I would say some of these areas are ripe for legislative action. And to truly make progress on, I think we'll not just rely on market behavior, but on changing laws and regulations. And so, for example, I would highlight here not an area of perhaps the biggest spending, but out-of-network billing continues to be an area of spending, and also distorts market behavior and causes real harm to patients. Many other states have passed laws to address out-of-network occasions where patients are going out of network through no fault of their own and receiving exorbitant bills. And other states have passed laws that take the patient out of that process, importantly protect them from these huge bills, and set up a fair and reasonable process for reimbursing the provider for the care that was being provided. So there are areas here where that market behavior, I think, could make some progress on, and maybe we'll hear from some testimony today on that point. But I would also say areas where legal and statutory changes may be warranted.
Thank you. Very good. Yes.
I just have a question around the hospital readmissions. Does that include coming back to the emergency room, or that's just inpatient?
It's just inpatient.
It's just inpatient.
Yeah.
Okay. So do you have breakdowns of why, of what brings people back, what that would be. Is there some amount of that that's mental health or substance use disorder?
Yes, I think.
Actually, Z is a real expert on this. Is there any way we've looked at not just readmissions of people revisiting the emergency department and not being readmitted?
Yeah.
Another, Z,
That
and
we'd be interested in.
The people that do it, behavioral health comorbidities are a major part of what causes people to go back to the hospital. But Z is actually our expert on that.
Yeah, I think behavioral health comorbidities are a huge driver here.
Okay.
And certainly the data does bear that out.
Yeah, great. And then the prescription drugs, you did say that it was, well, one of the highest, fastest growing categories in spending, but we don't, if we limit the growth, 230, I mean, that's not chump change, but compared to alternative payments, other, things, it's not. How did you come to that number? Is that, I'm just trying to understand the difference between the savings and the amount.
Sure. I mean, a lot of these scenarios, we had to choose something relatively arbitrary. We could have chose a tougher target there. In that case, it was thinking about the 3.1% growth and dividing that between price increase and use of drugs, utilization increase, and we just divided that in half. So that's where that comes from.
Okay.
But sure,
It was only the top 30 drugs.
yes,
right?
and it was only a subset of drugs. So, you could imagine a tougher goal there, and there would have been more savings. So I wouldn't read too much into, oh, that's a smaller potential.
Okay, thank you.
Stuart? Two quick points. On the readmission, we need to note that the cost benchmark hearings last year, we got some reports on health services research that since has further accumulated, suggesting that it's a little worrisome that pushing hard on readmissions may be associated with increased mortality rates, and we need to get the facts straight on that and see. It sounds like you're going to be helpful with that. We don't know yet, but there's a little bit of an orange light on. I'll ask. I know we're short on time, but I want to ask a quick question to David and Ray about case mix. When we look at individual rate increases when we're wearing our other hats on plans and providers, a lot of the very large rate increases the providers or plans attribute to increases in severity or repairing problems in coding severity. What we're seeing today is not severity adjusted data. This is just flat out expenditures. I'll admit personally to some concern and worry about the legitimacy of those recoding. I think we need a close look at that. But would you comment on that? Is there any chance that we're looking here at a change in the actual severity needs of the population, or do you really doubt that that's what's going on?
Sure. Yes, you're right. We see reported health status. When you look at the diagnoses people have and the way those are coded, we see increases year after year that are not plausibly a true health worsening of the population. It's hard to know exactly how much the population health is getting worse, but you can look at survey data and other prevalence and incidence data and so on, which we have, and it looks like a minority of what people are reporting as an acuity increase is actual health issues. We see the opioid epidemic is certainly a contributing factor to a true health issue, but overall, it looks like our population is healthier than the national average, and it's not significantly getting worse. That's what you tend to see.
Let me, David, do you want to make a comment? Because
the last thing I was just going to say, we did do an analysis around, we are an aging state, and as we age, we will use more healthcare services. And we estimate that to contribute about 0.5% annually. So if you think of the 3.1% as the target, we're starting right out of the gate probably with 0.5% growth just due to the aging of the population.
let me, we're going to get an opportunity as the commission itself and our April 3rd to go into more depth on any of these questions. I want to make sure, thank you, sir. I want to make sure that our legislative friends and the opportunity make sure that you have. So please.
Thank you, Mr. Chairman. Just, I'm curious about readmissions. Correct me if I'm wrong, but were readmissions in hospitals going down several years ago, maybe 6, 7, 8 years ago? Was there a trend that they were going down, and have they now started coming back up because of behavioral health? Is that what you're saying?
How far back do we go here?
So 2001.
Yeah, that appears that we were going down a little bit in the early 2010s, 2013. Yes, and I don't know if, I don't know if behavioral health is driving that U-shape.
That would be interesting to see, because it seems to be, this whole opiate crisis and the behavioral health behind it. If we started looking at more behavioral health and servicing behavioral health, it could possibly help save the overall healthcare system.
Yeah, so if the slide you're looking at is slide 24, and you do see from 2011 to 2013 our rates, and if you just look at the Medicare, which is the best comparison to the United States, following a very similar trajectory. And this was at a time when there were new penalties established for hospitals to reduce their readmissions rates. And since that has gone up, I would say, in terms of what has caused that U-shape, I don't know that maybe Chia will be able to better answer, but I would say during the same time period, we have seen a significant increase in patients with behavioral health issues are showing up in the emergency department. So I think over literally about the same time period, there's been a 25% increase in patients with behavioral health care diagnoses showing up in the ED. So that could very well contribute to higher readmissions on the back end.
Yes, sir.
Thank you, Mr. Chair. Want to ask about, I see on the HPC recommendations, there's category 8, which is broad but critical, social determinants of health, but then when you get into the opportunities for savings, that wasn't highlighted. So can you talk a little bit about just some of the thinking around, from a public health perspective, from a social determinants of health perspective, how do we really meaningfully get our hands around that? And is there any analysis specifically around savings? I'll admit I have a hefty bias here, but I think it's an important topic.
Great. So I'll take a shot at this, and maybe, Madam Secretary, you can speak to some of the true innovations the Mass Health Program is conducting in this space as well. One, I would just say in terms of these modeled scenarios that we did last year, this was clearly a subset of opportunities and is not intended to be a kind of a comprehensive list of where those things are. And I think one of our goals is to update this from time to time, and I could certainly see an analysis where there's emerging evidence that, for example, having patients in stable housing does seem to have an impact on healthcare utilization or reduced emergency department utilization. Things like nutrition, again, emerging evidence that these can have real impacts on the downstream healthcare costs. So we are big believers that these things do need to be thought of holistically. And right now we're launching a whole set of investments in providers in Massachusetts through one of our grant programs to test and continue to contribute to the evidence base about how does the medical system, together and in partnership with community-based organizations and social service providers, work together to address the whole person needs of these patients. And that is, I think, still a journey that we and many other states are on. I would say as one of our advantages has been the restructuring of the Mass Health Program, which has put a lot of emphasis on helping to build and strengthen those connections, as well as having some, for the first time, actual reimbursement for some of these services that were typically not considered medical services. And so I think look forward to continuing our work in this area, continuing to add data and evidence around the importance of addressing upstream social determinants of health.
All right. David, I want to, I'm sorry. Did I miss, please?
So just to pick up on what David said, so part of the ACO restructuring of the 850,000 lives in the ACO, as part of the primary care screening includes screening for housing instability and food insecurity, which is the first time ever in the Medicaid program. So we should have data at the end of the calendar year that sort of shows at least what we're screening. as well as starting in January of next year, actually rolling out that part of the waiver that actually will be paying for, again, first time in a Medicaid program, paying for some of the things that are screened for around social determinants. It's not where we'd like it to be, Senator Sear, but it was what we got the feds to approve.
Could I just note, on the issue of social determinants, CHIA is making a major effort to invest in understanding social determinants, because a lot of understanding social determinants is about linking data sets. If you think about the fact that we now know that construction workers are 6 times as likely to have an opioid overdose in this state, that's understanding the association between employment status and opioid overdose status. It's linking databases. And so CHIA has developed some very sophisticated ways of doing de-identified data linking. And so we're working with other agencies increasingly. And the Chapter 55 work that we've done with DPH is really the crowning example of this, of linking data sets from across state government to see the social drivers behind some of these medical and other social problems we have. It's a major area for us, for sure.
So, did you want to say yes?
Sure. Thank you very much. Just a clarifying question in the opportunities for savings. Is it in the report put out there like each of those opportunities categorically could exist separate and apart from one another, or is it that the readmissions need to be tied with community health and reallocation of care there, whereas those two would really need to be combined in order for one or the other to exist? And then just following up on that, is there any analysis on, is there actually the infrastructure and staffing that exists to make that happen?
So I would say on the opportunities, on the opportunities for savings investments, in that little, in the report that we have, it does talk through kind of the methods for each of the different scenarios. We did conduct each of those individually. I would say in the case of, for example, reductions in avoidable ED use, we did offset the savings by saying many of these patients would be going to a primary care office. And so we did offset to say it's not just that we reduce the avoidable ED and those patients go nowhere, they just may receive services in a lower cost setting. And so there was an offset there. I would say on readmissions, we did not attempt to do an offset about the real necessary investments that would need to be made in the community to support those patients to reduce that readmission. So I think you're it is very fair and right to say that in that case, you would need to reinvest some of those savings back into the types of supports necessary in order to reduce the ultimate acute care utilization. But happy to kind of speak more to that offline.
So, first, I want to thank all of our speakers, but I also want to get back to why we're here, and that is to discuss the benchmark, because I don't want to lose sight of the fact that overwhelming evidence suggests that the major driver for increased spending is increased spending. And it is the prices. There's an old statement, it's the price is stupid. And you saw that in the charts that were indicated. So while it's all well and good, and I think we've been working hard to identify some areas, what is really separated Massachusetts from other states is the benchmark and the fact that our providers and our payers are really paying attention to spending and allowing them to try to be more efficient and to work harder to make our system work better. So that's why what we're here is so important. That benchmark is really the key. And so we're now going to turn to testimony from the various stakeholders in the system. So do we have an updated list? Thank you so much. So, Michael, you are going to be the leadoff here. So, did you like to say? Yes.
Yeah, I'm sorry not to interrupt, but another one of the members is here, Representative Joe McGonigal. If he'd like to come down, I'm giving him the option to come down and sit with all of us. You're welcome. And I had neglected to recognize Representative Mearos here, so thank you. And just as a warning, the House will be entering formal session fairly soon. If you see all of the House members get up at the same time and walk out, it is not because of your testimony.
Thank you. So our first witness this afternoon is Dr. Michael Wagner, who's the interim CEO of WellForce. Michael, it's always a pleasure.
Thank you.
And we're going to try, if you'll excuse me, to keep your remarks within the 5-minute area. I don't like to shut anybody off, but, just if you can be
I did
conscious
test
of...
earlier today, and I think I'll be able to meet that standard. Okay. Good afternoon, Madam Secretary, Madams Chairman, chairs of the Joint Committee, Chairman Altman, and members and commissioners. Thanks for the opportunity to testify this afternoon on the cost trend and benchmark. I'm proud to be leading WellForce, which is an organization that started with a collaboration between Tufts Medical Center and Lowell General Hospital and has grown through the addition of Melrose Wakefield Healthcare and Home Health Foundation. And all through the beginning and into our work now, we have relentlessly been focusing on the concept of transformation in healthcare delivery. And we know it's here, and the dialogue you've had today is emblematic of the conversations we have in our offices and our boardroom, and we applaud the work that you're doing. We dedicate our energies to enhancing and expanding the delivery of care by keeping care local, by creating highly aligned physician networks and communities, and driving to value. A couple of key facts about our system. We're comprised of 2,400 physicians throughout eastern Massachusetts and 2 clinically integrated networks, an academic medical center, Tufts, 4 community hospital campuses, 6 home health care organizations, 13,000 employees, $2 billion in revenue. We're committed to the value-based contracts. We have over 400,000 lives in some form of value-based contracts for which we're at risk, 50,000 members in the Mass Health ACO in collaboration with Fallon Health, and we're committed to this concept of the journey from volume to value. Regarding the 3.1 benchmark, we're in agreement. We have to continue to work very seriously in terms of reducing our healthcare costs, and we applaud the work of the Health Policy Commission in outlining the items that David talked about earlier. Our biggest concerns, we have a couple of concerns. One is pharmaceutical costs. I'm not going to go into details, but that's been an ongoing issue for hospitals and for our patients, overall pharmaceutical costs. Another area that's emerging for us, and it's always been an issue, is employment costs. We are, in some ways, in the state of Massachusetts, victims of our own success. The casino that you've seen built on the highway going north of the city is a great testimony of the work that's been done, but they're employing and working very hard to fill their slots. And for many administrative and managerial positions, they are now a competitive threat to our organizations, both Tufts and Melrose Wakefield, which is right in their backyard. And we're seeing employees at the lower end of the scale being offered jobs for dollars more per hour, which is creating an issue in terms of being competitive in the workforce. It's a great thing to have for the state, but from a cost perspective, it becomes an additional stress. Employment costs, and I would say for most of our organizations, we plug somewhere between $2 to $4 million on an annual basis to make up for employment cost disparities as we have to adjust our workforce payments. So this additional pressure is just another piece that's out there. So I'll put that out there. The other point I want to make, and it came up on David's slide, is provider price variation. We haven't talked, it was a big topic a couple of years ago. It's kind of gone into the background. I would make the argument that when looking at opportunities, especially when it comes to price, as you said, the price variation issues that exist in this marketplace are not insignificant, and I would argue they're probably comparable to the last slide that David showed in terms of opportunity for 5-year savings that would be in the billions of dollars range. So we would urge that the Health Policy Commission continue to address and develop a method to narrow the wide disparities that exist in provider prices so that that could actually be another lever in the state for reducing our overall costs. The last couple of comments is around transforming care and bringing it back to the communities. And importantly, the work that we've been doing with Tufts and the distributed models, to work with Lowell General Hospital, to work with Melrose Wakefield to bring that care back to the communities. It is also on the list of things you're looking at, which is on helping hospitals, and it's been an area that we've talked about in the past, is making sure that our community hospitals are vibrant and can weather the storm as we go through this transformational change. A couple of points I want to echo what Secretary Sutter said in terms of the urgent care not requiring a referral for the ACO, and we're part of that, and that does make it easier for patients to access care in a more convenient location. Hospital costs and the hospital costs that I talked about with provider price variation, but also the expansion of the use of outpatient licensure, which was also mentioned in David's presentation, is a tactic that has been used by hospitals as they've acquired physician practices. We would certainly recommend that the Health Policy Commission spend more time looking at the dynamics that occur on the physician network side and the acquisition of physician networks by hospital systems as another cost driver in a bad direction. So I want to thank you for the opportunity. We're optimistic. There's been a tremendous amount of work. Massachusetts, as always, has been a leader. We appreciate the opportunity to testify today. We appreciate the work that you've all been doing both on the Joint Committee but also the Health Policy Commission. And thank you for the opportunity to testify.
Presenter representing the Massachusetts Medical Society, Brendan Abel. Brendan. Thank you for coming.
Well, good afternoon. My name is Brendan Abel. I'm from the Massachusetts Medical Society, representing some 25,000 physicians, physicians in training, and medical students across the state. I appreciate the opportunity to be here to provide some perspective on behalf of the physician community. Unfortunately, this happens to coincide with the meeting of the Medical Society's Board of Trustees, so you're stuck with me today. I'd like to offer just a few brief remarks on the benchmark itself, and then a few observations on cost containment generally from the physician perspective. So first, as to the benchmark, the Medical Society encourages the retainment of the current benchmark at 3.1%. We think it's important to retain this aggressive goal of intentional cost containment below even prevailing rates of healthcare inflation. MMS supports the continuation of ambitious benchmark goals in the hopes that our state will continue to provide even higher value care, and importantly, that these relative cost savings will be appreciated by all patients in the form of constrained or reduced out-of-pocket expenditures. Second, we joined many of you in reading with pleasure CHIA's annual report that showed continued restraint in cost growth. And we took time to scrutinize the sub-analyses that HPC has put out over the past many years to better understand, as many of you have been looking at as well, what are the drivers that have led to many of the successes over the past many years. And we at the Medical Society have been heartened to see the role of physicians in cost containment. In 2016, physician spending grew just 1.7%, and it grew at an even lower rate of 1.2% in 2017. This has meant that physician spending has represented just 7.7% in 2016 and 8.4% in 2017 of total spending increases over the past 2 years. I'd be the first to acknowledge, and it was referenced in earlier conversations today, that those types of sector-by-sector analyses come with a lot of nuance, and we would welcome the opportunity to unpack them, but we think that there are important messages contained therein. And this stewardship of healthcare dollars by physicians has been confirmed in other ways at the national level as well. Just this year, a study came out indicating that physician-led ACOs spend 14 to 25% less per patient than ACOs led by academic medical centers and achieve high-quality marks. Third, I'd like to comment briefly on two priorities that you, the HPC, articulated for this upcoming year, and which are certainly shared by the Medical Society. First, we absolutely share commitment to address administrative complexity. Not only does the physician community see this as a driver of unnecessary cost, but we also think that it could be a driver of physician burnout. In fact, this year, in conjunction with MHA and the Harvard School of Public Health, the Medical Society authored a white paper on physician burnout. Burnout among the nation's physicians has become so pervasive that this paper, authored by one of your friends, Dr. Ashish Jha, and others, declared that physician burnout is a public health crisis.
The consequence of burnout includes reduced hours, early professional exit, all coming at a time when assuring an adequate physician workforce is imperative. This paper includes directives aimed toward curbing the prevalence of burnout among physicians and other providers, including the appointment of executive-level wellness officers, proactive mental health treatment and support for caregivers that are experiencing burnout, and improvements to the efficiency of electronic health records and other areas of administrative complexity. We urge you to add this subtopic into your discussions on administrative complexity, and we would certainly welcome the opportunity to engage further on this issue. Lastly, the Medical Society has made addressing pharmaceutical drugs costs a top priority. Not only has MMS noted the HPC's annual reports that have successively showed pharmacy costs as a leading driver of healthcare costs in Massachusetts, but practicing physicians regularly note the daily frustrations of trying to ensure their patients have affordable, timely access to prescription medications, whether it's some of the new emerging technologies or generics and insulin and drugs like that. In conclusion, we really appreciate the opportunity to provide comment. We look forward to continuing to work with the Health Policy Commission and the Joint Committee on Healthcare Financing on promoting broad access to high-quality, affordable care in Massachusetts.
Thank you so much. As David Seltz indicated, we are putting high on our list the issue about administrative complexity, and we'll be more than happy to work with you to make it happen. So thank you so much.
Thank you. We look forward to it.
Diane, if you wouldn't mind. So our next presenter is Diane Anderson, who is the president and CEO of Lawrence General Hospital. It's always a pleasure to have you join us.
Thank you, Chairman Altman, Executive Director Seltz, co-chairs of the Joint Healthcare Finance Committee, Secretary Sutters, all the commissioners, and the HPC staff. Your work is truly invaluable, and I appreciate the opportunity to be here again to talk with you. You have heard my message before, and it has many similarities to what you heard from Dr. Wagner, but I believe it's very important to keep this issue in the spotlight. The health care cost growth benchmark causes unintended consequences. At the same time, it's trying to preserve a high-quality, low-cost health care delivery system in Massachusetts. As the CEO of Lawrence General, I'm testifying to share a perspective that is common among underpaid, urban-based community hospitals. The role we play and our vantage points are important, particularly in a Commonwealth where health equity and ensuring that all populations have access to quality of care is our goal. LGH, located 29 miles north of Boston, is a regional medical center. Annually, we serve over 70,000 emergency patients in our Level 3 Trauma Center. We have about 500 affiliated physicians and a net patient service revenue of over $250 million. We are the first choice for residents of the Merrimack Valley, including the Andovers, Lawrence, and all the surrounding towns, for community-appropriate health care. Our most significant challenges are our very low relative rates of payment from commercial payers and very high exposure to Medicaid, for which we're now at risk through the ACO. But in spite of these significant challenges, we have a strategy for success that is working. While the overall philosophy of the cost growth benchmark is a good policy, it has not played out well for us. It has been used as basically a rate cap for commercial rates. The result is that our commercial rates are consistently the lowest and getting lower. CHIA just published the statewide average relative price that each hospital was paid by the commercial insurers in 2017, and LGH, once again, is third lowest in Massachusetts. We've actually gone down from the fifth. It was never the intention of the cost growth benchmark to perpetuate unwarranted and wide disparities. Starving the most efficient providers of resources costs consumers in the Commonwealth because it limits our capacity. If all the health plans in Massachusetts were to pay us and all the other providers who are paid less than 90% of the average relative price at that level, it could be done within the current cost growth benchmark and have plenty of headroom for other cost growth. My colleagues and I are focused on the persistent, unwarranted price variation, and we will need legislative intervention very soon. If we were paid the cost growth benchmark at 3.1% year after year, even if other providers were paid half that, we would never get to the average relative price in our lifetimes. The other key issue I would like to bring up today that I believe has a major impact on overall costs of care is the site of care. With the strategic investments that we've made in recent years, LGH has experienced consistent growth by every measure. Both case mix and volume are up substantially. Investments in state-of-the-art surgical suites at the hospital and a new Andover Medical Center are keeping patients local. This enhanced local access has allowed us to stem some of the outmigration to Boston and retain care at our high-value, high-quality hospital. The growth tells a valuable story. Some call it David and Goliath. Those of us in community hospital settings know it's just a matter of resources placed in the hands of efficient operators. My peers in Holyoke, Brockton, Cambridge, Lowell, and Gardner can tell a similar story. When patients choose LGH over higher-paid providers, it saves the Commonwealth. Every patient we attract and care for at LGH saves costs. Whether it's an angioplasty or a hip replacement, the savings quickly add up to hundreds of millions of dollars. For example, last year we cared for almost 2,000 patients whose case weights, which measure the intensity of care, were very high, over 3 for surgical DRG and over 1.6 for medical DRG. If that care had been delivered at one of the average for Boston hospitals, it would have cost over $20 million more. Although our strategy has been working to date, even with the continued unfair commercial payment levels, we will not be able to keep pace, and the care that belongs in the community will end up in the higher-priced facilities. This is not fair for patients, and at the end will cost the system. On September 13th, our trauma service capabilities, our emergency response, and our surgeons and teams of caregivers saved lives that could not have been saved if LGH did not have that high clinical capability. The ability for us to continue to invest and grow is not supported by any policymaking in Massachusetts currently. I urge the HPC and elected officials leading healthcare policymaking here today to embrace an opportunity to achieve real cost savings by making the cost growth benchmark more strategic in its focus, to bolster providers like us where access is efficient, high quality, and a model for cost savings. Thank you for your thoughtful consideration.
Well, thank you, Diane, very much. And I just want you to know, I think I speak for my fellow commissioners and the staff. We have made expanding community care a top issue from the beginning. And under no circumstances should the 3.1 or any other benchmark be viewed as a cap on all payers. I think your comments are very appropriate, and we will continue to work to sort of make sure that the system is as efficient as possible. So thank you. Your message, it doesn't go in vain.
Thank you all very much.
All right. Our next speaker this afternoon, it represents the Massachusetts Health and Hospital Association, Michael Skorzinski. Michael?
Chair Benson, Chair Friedman, Chairman Altman, members of the Commission, members of the committee, thank you for the opportunity to offer some brief comments here today. MHA's member hospitals and health systems are committed to creating a delivery system with affordable, accessible, and high-quality care. And we believe we have a promising story to tell nationally, starting with the state's expansion of access, initiating back with Chapter 58, to our ongoing efforts to constrain the growth of healthcare costs. Massachusetts serves as a paragon for the promise of healthcare reform and universal access. A key component of this effort was Chapter 224, which set out an ambitious and unique goal. With the guidance and assistance of the Health Policy Commission and EOHHS, the state has made real and continuing progress since its implementation. But we know we have much further to go. That's why MHA supports keeping the benchmark at the aggressive level of 3.1%. In doing so, however, we hope the Commission recognizes that many factors and challenges to the healthcare cost equation remain largely beyond the direct control of hospitals and healthcare providers. Our written testimony outlines many of these concerns, but not surprisingly, and you've heard them over and over today, they range from rapidly increasing pharmaceutical costs and labor shortages in specific areas, to changes in federal health care policy, to the effect of demographics in an aging population, to administrative complexity, and to, yes, certain payers using the 3.1 as a cap, which has particularly negative consequences on community hospitals and only contributes to the variation concerns which you've heard from the two hospital CEOs who preceded me here today. We appreciate the Commission's ongoing attention and assistance with these issues and the legislature's help in looking at them further. And we look forward to continuing our partnership in shoring up the success of the Massachusetts health reform journey. Thank you.
Staff has been wonderful, and we look forward to continue to work with you. Thank you so much. Our next presenter, Hannah Frigan, who represents the Healthcare for All organization that represents our consumers. Hannah, thank you for joining us.
Good afternoon. My name is Hannah Frigan, and I am the Associate Director of Helpline Enrollment and Education at Healthcare for All. Healthcare for All advocates for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. On behalf of Healthcare for All, thank you for the opportunity to submit testimony regarding potential modification of the healthcare cost growth benchmark for calendar year 2020. Given the ongoing challenges with healthcare affordability for our state's residents, we believe it is critically important to continue to pursue approaches that signal to the healthcare community that current efforts to address costs are insufficient. We therefore recommend that the Health Policy Commission continue to set the 2020 benchmark at equal to the potential gross state product minus 0.5% or 3.1%. In my role at Healthcare for All, I oversee the consumer helpline. Healthcare costs continue to be one of the most significant issues facing Massachusetts residents and are an issue that we consistently hear about from helpline callers. We hear stories on the helpline of families not able to afford premiums, deductibles, and copays daily. We also know about affordability challenges from sources such as the 2018 Massachusetts Health Reform Survey conducted by the Blue Cross Blue Shield Foundation and the Urban Institute. Data from the survey shows that our state's high levels of health insurance coverage does not guarantee access to health care or the affordability of care. Nearly half of adults reported difficulty obtaining health care over the past year, and 18.6% went without needed care because of the cost. Low and moderate income adults were more likely to report difficulties obtaining care and unmet need for care, including problems paying family medical bills and having to pay bills over time. Roughly 1/5 of all adults reported problems with family medical debt. The CHIA 2018 annual report on the performance of Massachusetts healthcare system also confirmed that having insurance does not mean that one is able to get all the care you need. CHIA's survey found that in 2017, over a quarter of survey respondents reported having gone without needed medical care or dental care due to cost, even though 2/3 of those individuals had health insurance at the time they needed care. The survey found that member cost sharing continued to grow at a faster rate than inflation, average wages, and premiums, while annual growth in fully insured premiums also accelerated, from 2% in 2016 to 4.9% in 2017. From 2014 to 2017, average out-of-pocket cost spending for people with employer coverage grew to 27%. CHIA also found that the costs of employer-based insurance are particularly burdensome and unaffordable to lower-income residents who have contributed nearly 1/3 of their income to healthcare expenses in 2017. And 29% of these residents had outstanding medical debt they were paying off over time. The 2018 HPC Annual Cost Trends Report highlighted some of this data from CHIA, acknowledging that many Massachusetts residents continue to face considerable challenges with healthcare affordability. The HPC reported that average total premiums for employer-based coverage in Massachusetts remain one of the highest in the country, with an average family paying over $21,000 per year in 2017 and a single enrollee paying $7,000 on average. The HPC estimated that when including typical copays and deductibles, health insurance spending for an average family in Massachusetts exceeded $23,000 per year, a figure that does not include other out-of-pocket costs for health care. We appreciate that the HPC outlined in the 2018 report a number of concrete strategies to address affordability, and we want to highlight the importance of addressing the rising prescription costs as a leading factor in the state's healthcare cost growth. High prescription drug costs result in higher premiums for individuals and employers and high out-of-pocket costs for consumers, as well as place a considerable burden on the state's budget. We've proposed a comprehensive legislative package to address high and rising drug costs this legislative session, and we recommend that state policymakers and HPC continue to support ways, in addition to pursuing an aggressive benchmark, to leverage other tools and strategies to ensure that consumer and patient affordability are at the forefront of efforts to address costs, including addressing prescription drug costs. Thank you again for the opportunity to share feedback for the healthcare cost growth benchmark.
I just want to make one quick statement. I want to thank you, and I want to thank Healthcare for All. I know I speak for many legislators in this room. If it wasn't for you, we would have constituents who would just be lost in the wilderness. So I appreciate all the work you do, especially the direct care that you give to the residents. Thank you.
Thank you. I couldn't agree more. Thank you so much, Hannah. All right, our next presenter represents the Massachusetts Association of Health Plans, Sarah Comedia. Sarah? Hi there. Welcome.
Good afternoon, commissioners and members of the committee. My name is Sarah Karamita. I'm the Vice President of Policy and General Counsel for the Massachusetts Association of Health Plans. Here on behalf of Laura Pellegrini, our President and CEO, who is sorry she was unable to make it, but she had other engagements in DC today, so again, you have me. So on behalf of MAP, we represent 17 health plans that provide coverage to approximately 2.8 million Massachusetts residents. We represent plans that provide coverage in the commercial, Medicaid, Medicare, connector, and GIC populations. So we appreciate the opportunity to provide you with these comments today, and we also will be submitting written comments that provide a little bit more information. So as the Commission's 2019 cost trends report noted, for the Massachusetts healthcare expenditures grew 1.6% per capita, which was far lower than the cost growth benchmark set by the HPC during that time. While we should be proud of this achievement, and it's the product of continued pressure and accountability to rein in spending across the stakeholders, the fact remains that Massachusetts healthcare costs remain among the most expensive in the country and are continuing to grow. We think it's really important not to lose sight of this fact. And so while we have room to celebrate, we definitely believe that more work needs to be done. Massachusetts are the second highest cost in the nation. And this results in very real challenges, as we've heard, for consumers and employers, families, businesses, and the state healthcare budget, putting pressure on all of the above. So there's much more work to be done to make healthcare more affordable and improve the quality of care. So we must not lose sight of our mission to control healthcare costs. For the MAP plans, as premiums reflect the cost of care, holding ourselves accountable to a strong cost growth benchmark and addressing the cost drivers that have been identified today, we believe are essential to going along the way to making healthcare costs more affordable. So for these reasons, we support keeping the aggressive benchmark at 3.1%. We believe this will continue the pressure on the system and to work to make healthcare more affordable. So we are privileged that Massachusetts has a wealth of information and data to identify the specific healthcare cost drivers. Over the past 9 years, there have been nearly 30 state reports that have examined these, and time again, the findings remain consistent. As this year's report notes, prescription drug and hospital outpatient spending remain the highest areas of growth. Other factors that were found to contribute include the persistent increases in prices that doctors, hospitals, and other providers charge, low-value screenings, tests, and services identified as unnecessary, and care largely being delivered in high-cost settings by high-cost providers. As stated in the report, and today by Chairman Altman, it continues to be the price. So it's essential that our efforts remain focused on these cost drivers and on addressing the price, as we believe that will result in the greatest impact for consumers. So with respect to prescription drug prices, we'll go into more detail in our report, but I would like to highlight, as found in this report, but also national trends are consistent. Prescription drugs are one of the key cost drivers, and therefore the state must undertake efforts to hold pharmaceutical manufacturers accountable for the prices that they charge. As the Commission considers measures the system's performance against the benchmark, it's critical for pharmaceutical manufacturers to justify their price increases, and we support recommendations related to increased transparency around pharmaceutical costs. While health plans and providers are subject to the benchmark, similar accountability is needed for pharmaceutical manufacturers. We therefore support proposals to add pharmaceutical manufacturers to the cost trends hearings to explain the reasons for their high prices, and similar recommendations for transparency and oversight that were included as part of this report. We definitely support those recommendations that have been in this report. Finally, addressing provider prices and care in high-cost settings. As we've continued to maintain over the past 9 years, more than 24 state reports have examined these drivers, and report after report have found that provider prices remain the most significant factor driving healthcare costs. As found in the Commission's report, total spending per patient varies substantially by provider system. And one example was the 30% differences in primary care spending per patient depending on where the primary care physician was affiliated. On top of this, as the Commission's February 2019 presentation noted, the Health Policy Commission has received 96 material change notices, with 39% of those transactions involving physician group acquisitions or contracting affiliations, increasing market concentration for physician services. 21% of the transactions involved a merger, acquisition, or network affiliation of an acute hospital, which included the most recent multi-hospital merger. We therefore support the Commission's continued efforts to monitor whether the transactions that have been approved have resulted in lower costs and better care for employers and consumers, and to continue to monitor whether proposed mergers and transactions will provide value and reduce costs for patients. We believe this is a critical part of the Commission's charge and important for containing these prices. We also believe that the Commission should continue to focus on factors looking at how results for these mergers align with the anticipated benefits that providers articulated in their material changes, whether or not they have leveraged higher prices as a result of these transactions, and what impact the concentration of institutions is having on the ability to meet the benchmark. We believe, again, these are important and will help us continue to address not only the high prices, but the considerable variation in prices. So again, we will submit longer comments, but we thank you for the opportunity to make these comments today, and I'll take any questions that you have.
Thank you, Sarah. All right, very good. Our next presenter representing the National Federation of Independent Businesses, Christopher Carlozzi.
Thank you, Mr. Chairman and members of the Commission, Chairman Friedman and remaining members of the Joint Committee. Thank you. My name is Christopher Carlozzi, and I'm the State Director for the National Federation of Independent Business, representing more than 5,000 small businesses across the Commonwealth. Our members are involved in all types of industry, including manufacturing, retail, wholesale, service, and agriculture. The average NFIB member has 5 employees. In short, NFIB represents small Main Street business owners from across our state. Small business owners in Massachusetts have ranked the cost of health insurance at or near the top of their list of concerns for well over a decade. The price tag of health care in the Commonwealth is a significant cost of doing business and a significant consideration when creating a new job. And while healthcare spending growth may have slowed to an impressive 1.6% in 2017, for small businesses, health insurance expenses continue to increase annually, with efforts to get the cost increases under control seeming to always fall short of expectations. While individuals and government employees are experiencing some health savings, small businesses are once again reporting premium increases. In fact, the Health Policy Commission's 2018 Cost Trends Report found Massachusetts small businesses and their workers facing the second highest health expenses in the nation. Small business owners cannot fathom why they face continual health cost increases, yet individuals and GIC-covered workers are seeing lower costs. It begs the question, why are small businesses facing the second highest health care costs in the nation, and individuals covered through the Health Connect are experiencing the second lowest? Some would argue that our unique merged market is resulting in an unfair cross-subsidization, where small businesses are paying higher costs, resulting in individuals paying less. When the 2006 health reform law was passed, merging the individual and small group markets, a series of ratings factors were included to prevent premium rate spikes for small businesses. However, under the Affordable Care Act, these ratings factors that once protected small businesses are gradually being phased out. After 2019, the remaining factors allowed by the waivers will be completely eliminated, and small businesses will face even greater cost increases. This is a major problem that we hope the legislature can address this session. The 2018 Cost Trends Report may have reported growth well below the benchmark, but a small business's ability to offer affordable health coverage for their workers has in no way improved. Since passing the Massachusetts health reform law, elected officials have touted those reforms as a major success. This has not been the experience for the state's smallest firms and their workforce that struggle to find affordable coverage and face annual premium increases and high deductible plans. Among Massachusetts healthcare reform efforts, cost has always been second to quality of care and access to insurance. But it is time to recognize that cost is the biggest barrier to care. Small businesses can no longer endure annual double-digit premium increases, much like the Commonwealth is experiencing. Healthcare expenses are also devouring small business budgets and crowding out revenue to grow, hire, and expand. Health insurance costs are not contained within a vacuum for Massachusetts employers, facing across-the-board operating and labor cost increases. Our state is prohibitively costly to run a small business, with highest-in-the-nation energy costs, mandated paid sick leave regulations, high unemployment insurance rates, high wages, and the cost associated with a new paid family and medical leave benefit. A large number of small businesses were also subject to the EMAC assessment for the past 5 quarters. Small business owners were completely overwhelmed and caught off guard by this new Massachusetts-only expense. What is perhaps most frustrating is that small businesses are being penalized for something they have little to no control over. As health insurance costs become more unaffordable and higher cost, high deductible plans more prevalent, workers are opting for state-subsidized coverage instead. The worker is simply making a budgetary decision that is best for their family. Small businesses are offering the most affordable options available and cannot prevent workers from seeking state-subsidized coverage without re-implementation of the now-defunct employer gate. Yet the state is penalizing employers for their workers' decision to seek affordable coverage. This new assessment does nothing to make health care more affordable for businesses and their workers. It simply piles on a new labor expense, further straining small business budgets. But solutions to health insurance cost crisis for small businesses and their workers who shoulder the premium costs are often difficult to implement. NFIB was pleased to join a collaborative effort with other business groups in the state to help change consumer trends and reduce emergency room visits, as we heard about earlier today. The initiative calls for Bay State employers to help educate their workforce on appropriate ER usage in order to help provide approximately $100 million in cost savings over a 2-year period, roughly a 20% reduction. Other cost-saving measures include more transparency for consumers by providing them with more choices. NFIB strongly favors more free market solutions to lower costs through competition and choice. Government must seek a way to instill competition into healthcare by reducing mandates. Many medical procedures are not emergencies, and consumers can be given information that allows them to choose the best care and the most cost-efficient care. For the sake of the economic well-being of Main Street businesses across Massachusetts and their workers, we must work to reduce health insurance costs for thousands of struggling small businesses. So while cost growth may have slowed, for small businesses, they are still experiencing a lot of financial burden due to healthcare cost increases. Thank you.
Thank you very much, Madam Secretary.
Thank you, Chris. First of all, I want to thank you for representing the small businesses in Massachusetts, because they represent actually the economic backbone. The largest industry is actually Massachusetts. Just a couple of things. As you may or may not know, today is Wednesday. I am oriented to all 3 spheres. On Tuesday, the Connector formally submitted an application under the Affordable Care Act, Section 1321E, asking for full restoration of the small business rating factors. Not sure how those conversations are going, but we felt it was very important to not continue the phase down, but ask for us to actually have the authority to restore 2 very important rating factors in Massachusetts, not all of them, in recognition that Massachusetts is different than many other states. 1. 2, in fact, you commented upon the connector gate. That actually is going back up, or reinstated or rebuilt, or whatever terms, which was clearly something that when the Commonwealth had to come into compliance with the Affordable Care Act was compromised, shall we say. I'm trying to find a nice word, right? Compromise. Third, the administration acknowledged that the EMAC supplemental payment, the EMAC supplemental assessment, was meant to be temporary, and in the governor's budget is sunsetted as we made the commitment to the business community at the end of this calendar year. And fourth, I'd be completely remiss, sorry for the long-winded response here to you, I'd be completely remiss, since I am the chair of the Connector Board, I would really encourage small businesses to look at the small business platform of the Connector as opportunities for small business. I know that April is a big time when small businesses, particularly the micros, right, and like the really small ones, are looking for health insurance for their employees. It might provide some opportunities for employers to keep their costs down and provide greater employee choice, and would just really encourage working with the Connector for those members who see that as an option. That's the end of my spiel on the Connector for Small Business platform, but we acknowledge that there's been a disproportionate impact on small businesses.
Well, thank you. I appreciate that response, and certainly appreciate the attempt at a waiver again, and working with Audrey to make sure small businesses who do need that service move in that direction.
Absolutely. Thank you.
I, too, want to appreciate what you said, and thank you, Madam Secretary, because I think that, as you pointed out, you represent an important, critical component of our economy. So thank you for your presentation.
Thank you.
Okay. Our next presenter, representing Mental Health Legal Advisory Committee, Susan Fendel. Sue, welcome again. Good to see you.
Thank you for sticking it out. As part of the Supreme Judicial Court, a line item under the Supreme Judicial Court, we represent low-income people with psychiatric challenges, and we provide advice to anybody in the state. We have hands-on knowledge of the problems that people with psychiatric diagnoses face in the healthcare system, and for that reason, we present testimony on healthcare policy. I will be commenting on the recommendations of the Commission. Some of it is about low-value services, demand-side incentives, social determinants of health, the dangers of unmonitored integrated care for persons with psychiatric challenges, the unintended consequences of alternative payment arrangements, and ways to reduce cost. Great care should be taken in designating certain services or procedures as low value. For example, the evidence that the Choosing Wisely campaign relies upon is shaky. A 2018 study of their recommendations found that 7.8% of those recommendations rely on case reviews, editorials, or lower quality evidence. Only 22% relied upon primary research as their highest level of evidence. And the majority of recommendations rely on clinical practice guidelines, which themselves have problematic bases for their development. For example, 46% of the interventional guidelines don't grade their evidence. When graded, the majority of evidence was of the lowest level. Most guidelines don't comment on conflicts of interest, and of those that did, 91% of them noted conflicts of interest, primarily financial and monetary conflicts. So pricing upon the designation of a particular service as low value is problematic. We ask that you reconsider demand-side methodologies to reduce costs. People do not shop for their health care in the same way they shop for appliances. They, as a result of higher costs, they cut their medications in half. We know that. They avoid health care. Tiering of providers and facilities is not transparent and seems to rely on primarily cost and not quality. Shifting care from teaching hospitals to community hospitals may be fine in certain circumstances, but the tiering of hospitals is not granular enough to take into account that the more experience a facility has in performing a particular procedure, the better the outcomes. So when you're tiering a full facility rather than the procedure, you are actually pushing people towards inferior care. Lower spending for imaging doesn't account for the expertise of the readers or the quality of the equipment. If lower quality equipment is used, that may mean the difference between catching cancer in somebody or finding a brain lesion. We need real assessments of quality for all the measures, for value of services, tiering, and we need to include person-centered measures of that care. An example of outcome measurements that are not reliable includes revisits for hospital ED use. It doesn't include people who are not admitted. The fact that people who are not admitted to a hospital after being at it may avoid that hospital for readmission purposes because they didn't feel as if they got adequate care. People who don't go back to hospitals may not go back because they're so sick, particularly with behavioral health. If somebody is particularly depressed, they may not go to a hospital. They may just stay in their home. Readmission also may be avoided for fear of involuntary hospitalization. And sometimes people are directed to other hospitals after an admission. So admissions don't necessarily tell you much about the quality of care a person is getting and why readmissions go down. It's very easy to deny admission for a hospital. What is lacking in most of the outcome data is, or the measurement of outcomes, is that it's not measured, most of the data that is used to measure quality does not include actual outcomes. It does not include people's perception of their quality of life and how that care affects them. For example, the analysis of oncology drug pricing does not evaluate differences in outcomes. Recommendations also should
Susan, I need to ask you.
I'll go very quick.
What you're saying makes a lot of sense, so I hate to cut you off, so if you can bring it down then.
Okay. We agree on the funding of research, particularly for those services that are not funded for research because they're not profitable to any corporations. Alternatives are a great way to lower healthcare costs. Certification of peer workers and recovery workers is great if peers are included. Massage, meditation, acupuncture, that should be regularly covered. That avoids people relying on pain medication, which in turn lowers the amount of addiction that people experience. We agree with the negotiation of prices and controls on PBMs. However, we do not agree with tiering because somebody who has to use a drug that is more expensive cannot avoid that because they can't decide what their particular healthcare problem is, and it may mean that they're not able to use an alternative. Continuity of care can also lower costs. With behavioral health, the therapeutic alliance is the most important factor in recovery, and telehealth is great, but there has to be protections so that people retain the right to in-person care. Alternative payments can lead to cherry picking, and outcome measurements, because again, they can be faulty, do not control other costs. And finally, integrated care cannot, should not be pushed unless there is careful monitoring of the physical health care that people with behavioral issues get because of implicit bias and diagnostic overshadowing. Very often, physical symptoms are attributed to psychiatric conditions, and that eventually will lead to higher health care costs or to mortality. And that is it, and more information will be in our written testimony.
Your comments are very well taken, and I hope you'll work with our staff, because the one thing we do not want as we begin to have these aggregate changes is in any way negatively affect sick people that need better care. So you could be assured, and so I hope you'll work with our staff to make sure that they're very conscious of what you're talking about. So thank you very much.
Thank you.
So our next presenter, representing the Greater Boston Interfaith Organization, Bonnie Gilbert. Bonnie, welcome.
Good afternoon. My name is Bonnie Gilbert. I'm a member of the strategy team of the Greater Boston Interfaith Organization, or GBIO, and co-chair of the GBIO healthcare team. GBIO is a community organizing organization comprised of over 45 religious congregations and other institutions who come together to advance social justice, including issues related to healthcare costs, access, and quality of care. As many of you know, GBIO was a strong advocate for the creation of the benchmark right from the beginning at the negotiations for its inception under the 2012 Cost Containment Law. And we thank you, HPC, for the opportunity to testify here today on the question of whether the state's health care cost growth benchmark should be raised beyond the current rate of 3.1%. We have a simple answer: no. There is simply no basis for allowing a larger pot of funds for the market to fight over. The only results will be higher costs, not higher quality care. We fought for the creation of the benchmark, and we laud the excellent work done by the Health Policy Commission in monitoring, reporting, and creating policy recommendations impacting both the benchmark and the factors measured by the benchmark. However, we believe that the lawmakers of Massachusetts fell short of their duty when they created only this measure as a marker to help combat the continuing rising costs of health care as incurred and experienced by the citizens of Massachusetts. We also know that the primary out of order. As part of the discussion of the benchmark, we would like to take a moment to focus on one particular component of the benchmark formula, which is all patient cost-sharing amounts, for example, deductibles and co-payments. The purpose behind the creation of the benchmark and of the 2012 Cost Containment Law generally, as we all know, was to slow the growth of the cost of quality medical care for the residents of our Commonwealth. However, as noted in the Performance of Massachusetts Healthcare System Annual Report by CHIA, While total health care costs only increased by 1.6% in 2017, which was well below the benchmark, the out-of-pocket care costs for the patients and insureds increased by 5.7%. And yes, we understand that this is, at least in part, a reflection of insureds moving to higher deductible plans, and that this growth number will eventually slow as the share of the population purchasing these plans stabilize. But this does not address the problem. It only highlights the three significant underlying problems. One, that the patients, consumers, and insureds will still, in absolute dollars, be paying dramatically more out of pocket. Two, insureds are moving to these, in essence, catastrophic coverage plans because more comprehensive and financially protected insurance coverage costs even more. And three, from the data that you've noted in the cost trends report, the burden of all of this falls mostly on those people who earn just above the Medicaid level of eligibility. We also know that the primary reason for this number not commanding more attention is because its impact on the benchmark is so small. But the impact on Massachusetts citizens is not small. It is becoming devastating. The drivers behind this ever-increasing expense are price variation, has been discussed, unjustifiably high commercial prices paid to some providers or vendors. Two, inequitable policies for out-of-network billing, balanced billing, and surprise billing, such as the shortfall in coverage for mental health care services, which is resulting in patients having to pay hundreds of additional dollars out of pocket just to see their mental health care providers. Three, cost shifting, which is also a part of all of this. And four, dramatic increases in the price of pharmaceuticals. So, GBIO and the citizens of Massachusetts hold the HPC in high regard and consider it to be a greatly respected institution. For example, the work done last year in bringing the facts to the table regarding the BI-Leahy merger was of critical importance. It brought public attention to the real and significant problems expected by the merger, and by making the referral to the Attorney General's office, it enabled for the first time some significant, if only limited, enforceable conditions around cost and prices. Therefore, we would like to respectfully suggest that the HPC find ways through whatever means available to them as an agency under the law, and also available under the law, to bring more attention and more policy recommendations to the forefront to address the impact of these factors on those carrying the brunt of the burden of increasing healthcare costs in Massachusetts, namely the consumer patients, and especially for those with commercial insurance in the lowest wage and income quartiles. Thank you very much for the opportunity to testify.
Thank you so much, Bonnie. And I hope you'll go back to the organization and thank them for all the effort that you've done since the beginning of this effort. So thank you so much.
Thank you very much.
Okay. Our final speaker from my list, unless anybody, is Greg DeConcilius, the President of Mass Association of ASCs. Welcome.
Thank you. Good afternoon, Mr. Chairman and Commissioners. My name is Greg DeConcilius, and I'm the President of the Massachusetts Association of Ambulatory Surgery Centers. I'm also a practicing physician assistant working in orthopedic surgery and administrator of Boston Outpatient Surgical Suites, which is a multi-specialty ambulatory surgery center, or ASC, located in Waltham. I want to first commend the Health Policy Commission for the 2018 Cost Trends Report and for its continued efforts to reduce healthcare costs in the Commonwealth. The purpose of this testimony is to express our association's support for that goal and to discuss the value of ASCs in reducing outpatient surgical and diagnostic costs. I will mention that I will reference a few studies, but I'll submit written testimony where those citations will be for you in the interest of time. The 2018 Annual Cost Trends Report found that hospital outpatient spending, along with pharmacy, remain the largest drivers of total healthcare expenditures growth. Hospital outpatient and prescription drug spending were the fastest growing categories of spending in Massachusetts in 2017, with growth rates of 4.9% and 4.1% respectively. While this information is not surprising, given the fact that outpatient care is one of the fastest growing sectors of the healthcare industry nationwide, it also opens the door for a more in-depth discussion of appropriate site of service and cost and quality measures comparing hospital-based or affiliated outpatient facilities and freestanding entities. ASCs benefit patients, providers, insurers, and the healthcare system by providing increased access to high-quality, cost-effective outpatient care. Patients appreciate the conveniently located, community-based care provided by specialized surgery center staff under an organizational structure that permits greater individualization of care. Costs are lower at ASCs than hospital outpatient departments, or HOPDs, which translates into cost savings for patients. In 2014, Massachusetts patients saved $2.7 million on upper GI procedures performed in ASCs, with an increasing number of healthcare consumers with high deductible plans and out-of-pocket costs increasing at a rate of 27% between 2014 to 2017. Lower cost is obviously an important factor for patients. For this reason, ASCs are also supported by employers struggling with high healthcare costs and looking for ways to help their employees save money. Physicians appreciate the efficiency of ASCs. Surgeons can often perform more surgery in their block of surgery time in these specialized facilities. One health affairs study found that procedures performed in ASCs typically take 31.8 fewer minutes than those performed in hospitals without compromising quality. Physicians can also exercise much more control over their care given to patients in ASCs. ASCs in general are inherently smaller, and again, with specialized staff that I mentioned, it allows the efficiency to be a lot greater within these facilities. Public and private insurers also benefit from ASCs. On average, Medicare reimburses ASCs at 53%, or almost half, of the rate it reimburses HOPDs for the same procedure performed by the same surgeon. In 2014, Medicare saved $34 million on cataract procedures and $7.6 million on colonoscopies because its beneficiaries elected to have those procedures performed in a Massachusetts ASC. Another 2018 study done by the Workmen's Compensation Research Institute compared costs for knee and shoulder surgeries in ASCs and HOPDs in 18 states, including Massachusetts. Their results also exhibited lower costs in ASCs. Commercial insurers experienced similar savings. For the commercially insured population in the United States, an estimated $37.8 billion is saved annually by ASCs use. More directly relevant here in Massachusetts is Blue Cross Blue Shield's testimony to the Department of Public Health in September of 2016 on cost savings. In it, they noted that in 2015, only 8% of the $700 million Blue Cross Blue Shield of Mass spent on ambulatory surgery was spent in a freestanding ASC. They said, quote, if hospitals were to acquire existing freestanding ASCs and implement their own fee schedules, the cost of those services would approximately double, adding more than $60 million to the cost of care for Blue Cross members alone. Lastly, proving once again that competition benefits the healthcare system, another study on the impact of reference-based pricing on patient choices concluded that, quote, hospitals lowered their pricing for certain procedures in response to a loss of market share to competing ASCs. In conclusion, the Massachusetts Association of Ambulatory Surgery Centers is pleased to note that the HPC 2018 annual cost trends recommendations support more price transparency and ensuring access to high-value, low-cost settings and shifting care as appropriate to these settings. We strongly support these recommendations and appreciate the dialogue that has begun with the Health Policy Commission staff already on how ASCs can help meet these goals relative to the outpatient surgical and diagnostic care. Thank you for the opportunity.
Thank you very much, Greg, and very much appreciate your comments. All right, that brings the list to a conclusion. I just want to make sure that if anybody has any final comments. If not, remember, we will have our next. First of all, I want to thank you, Chair Friedman, and the staff and the other members of the Senate and the House for joining us. And remind everyone that we will have our final discussion about this on April 3rd. And so thank you all, and we are adjourned.